So now next we have with us Dr. Resnik. Please go ahead.
Thank you. Is the screen visible?
It is.
Wonderful. Who am I to start with? I am primarily a language technology person. You heard a lot from folks in that category in the previous webinar, and so I'm a little bit of an outlier today, but hopefully bringing in some other things that are pertinent to the discussion. I'm also on the Tech and Innovation Committee at the American Association of Suicidology. I was a co-founder of a workshop series called Computational Linguistics and Clinical Psychology, which is at the big Natural Language Processing Conference every year. Aya is one of the co-chairs this year and has been very instrumental in the success of that workshop. I have a big focus on trying to build community and connect the technological people to the rest of you, as you'll see. And I just want to start, in addition to providing just the usual appropriate heads up at the beginnings of a talk like this, I just want to say thank you to the organizers for this event and for the opportunity to be included in it. I want to start with this figure, which is from the 2018 paper by Coppersmith and colleagues on NLP as a screening for suicide risk. You've probably seen this before. One of my favorite papers from the last 4 or 5 years. Leaving out the technical details, what's important about this is that they developed a machine learning classifier to predict suicide attempts, and it, depending where you are on this curve, has somewhere between 90 and 94-ish percent true positives with only 10 to 20% false positives. And this is on the basis of social media posts. Now, one of the reasons I like this paper is that it is predicting attempts better than clinicians do, but also because it made great use of data donation as an ethical way to collect data. And it focused on a variable, an actual outcome or event-related variable, as opposed to proxy kinds of annotations or labels or buckets, as is very common in this kind of approach. Now, having said how much I like this paper, I have to say it raises the question that is being discussed today a great deal of, then what? What do you do when you have a model that is this successful? Never mind the false negatives, as Dr. Evat was talking about a minute ago. What do you do when you have all of these false positives, true positives? We have an overwhelmingly overburdened provider response system as things exist now. So just 2 days ago, there was this article in the New York Times about how basically the general practitioners, the primary care physicians, are the front lines because if access to the mental health professionals. They say if I call a child psychiatrist, they'll say I'll see them in a month. I was talking this morning with my wife, who's a clinical psychologist, and she said a month is optimistic in the extreme these days for this sort of thing. So what do we do about this overburdening? One of the key things that I want to focus on is the importance of domain experts in a role of helping the tech community understand what's needed, but the converse of the technologists helping the community of experts in these issues to understand what's possible. So what I'm going to talk about briefly are several different what's possible kinds of ideas that go beyond just the specific kinds of prediction that Dr. Evat and others have been talking about. So the dominant paradigm technologically here is one of classification. That is, finding the category that a person belongs to using conventional kinds of machine learning approaches. So no, low, moderate, and severe risk being a typical thing, if not doing a binary of some kind. But it's usually very difficult to understand why these classifications are taking place. And more important for the current point, the labels don't give you enough granularity. If you've got so many people being flagged who might not have been flagged before because the technology's gotten better, then what? How do you prioritize or deal within that population? And here I'm thinking in technical terms, obviously, better resourcing is the preferable solution to the problem, but we live in the real world. So what do you do when there are limited resources? From a provider point of view, you're not classifying an individual. You're dealing with a population of individuals that need to be paid attention to. And you need to figure out how to prioritize among those individuals. So it's not a classification, it's a ranking. And you have evidence, say, the social media posts of an individual, too many to look at to get a sense of what's going on with them, right? And obviously talking with them is the best solution, but that's the resource-bounded problem. So there needs to be a way of figuring out what is most important to look at within the evidence that you have about an individual as well. So we need to get beyond this taking a bunch of language and producing a label. Some work that I did with my recent PhD grad Han Chen Sheng and colleague Doug Ord involved a move from classification to the idea of prioritization. I won't go into technical details, but one of the key ideas was to get beyond this kind of single level approach of here's language, now assign a label or a score, to a multi-level approach where the words in what people have written or said helps you understand what sentences are important. The sentences help you understand what documents are important, and those things are leading to the risk level or score. So notice there was a notion of document or, say, social media post level importance in this picture. And if you have the ability to model that or estimate that, then you can take the individuals, those predictions of how severe or where you are on some sort of real numbered scale, you can use those things to rank individuals, but you can also then within an individual look at the ranking of the evidence, say the posts or documents, and then within that sentences and words that draw the attention to what's most important to look at in helping to understand what's behind this. This is real data from a study that we did, hence some of this is obfuscated for privacy reasons. So again, the technology view of the problem is this labeling thing, and we measure success using accuracy kinds of measures. But from a population level, what you need to think about, one perspective on what you need to think about, is that it's not about performance in the machine learning sense. It's about how many high-risk individuals you can identify given a limited time budget. And the results from this paper that I was describing were expressed in terms of results of simulations, similar to what Dr. Evat did, where what you were doing was taking a fixed time budget, like the number of at-risk people identifiable within a particular thing, say in the middle here, 3 hours, and the number of severe risk people who were identified within that time budget in the simulations. And the specific numbers are not important. What's important is measuring this. What's important is the idea of technologies taking something beyond just a classification or a labeling approach. So that even by itself, if it's improved, still isn't enough, right? Because again, if you're providing information to people who are going to try to assess the situation, figure out what's needed, possibly without having to go through the entire, basically this prioritization process cannot rely alone on conversations with individuals on the one extreme or labels on the other. We need something in between. So how do we help providers understand people's risk in context? So one way of looking at this is kind of the traditional classic top-down way. You have categories or constructs or patterns. So within suicide crisis syndrome, for example, Igor Galenker has identified a sense of entrapment or frantic hopelessness as a really important factor in this. And so one could go looking for those things in the language. Similarly, there's some really nice work by Stevie Chancellor and colleagues where they used categories both for risk and protective factors based in the literature to try to go and annotate or look for those things in social media. But there's another way of looking at this, which is the idea of going bottom up. What can you discover from samples of language that might tell you about categories or constructs that you might not have known were worth looking at or important? Or how are things that you do know expressed specifically in terms of the population you're looking at? So instead of a wall of language, right, we know that there are categories that are embedded in language. So in blue here, you have social isolation. In green, you have anhedonia, inability to enjoy things you'd enjoyed previously, vegetative symptoms related to exhaustion, and so forth. There are things you do know, there may be things you don't, and how things are expressed is very important. So one line of work that we've been doing in my lab involves a computational method called topic modeling, where it's an automatic technique that does not require training on labeled data. It works bottom up in order to identify topics or categories, sometimes referred to as themes, which are expressed as something that looks a lot like word clusters, bottom up in essentially a population of text from a population of individuals. So when you look at, for example, this college student collection that the previous thing came from, and you look for these categories that are discovered specifically in relation to big five personality neuroticism, which is often comorbid with depression. So this was, here is a variable we know to care about in the metadata, right? Then what you find are things like, well, in the lower end of neuroticism, you find things like going to sports, listening to music, going out to social occasions. In the higher correlations with neuroticism, it's not exactly correlation, but close enough, you have the vegetative system, energy level kinds of symptoms. You have the physical pains that often get people to the doctor when depression is an underlying issue. You have stress and anxiety. And the thing that I want to emphasize here is that what we're discovering bottom up is specific to the population that this set of text is from. If you were looking at a population of veterans or a population of postpartum moms, they would not be expressing exhaustion in terms of being late for class or missing exams or taking naps. They would not be expressing stress in terms of studying and nervousness about tests and so forth, right? So there's a body of computational techniques that can help us discover bottom up useful categories or expressions of categories that we already know about that are relevant to a particular population. And then we can use these models to apply them to text that we haven't seen before to say which of these categories is present and to what degree. A similar kind of approach is there in a way that can help us gain insights from lived experiences. And so I want to tell you, another quote from Rebecca Resnik, clinical psychologist. She commented, every lived experience is an N of 1. I mean, what does that mean? Everybody's lived experience is unique. We need to take lived experiences into account, but on the other hand, along with that, you can't do useful things with things that are one-offs, everything being completely different. You have to be able to find cross-cutting insights and generalizations if you're going to be able to make effective use of the information about people's lived experiences. And so we need a solution that takes the lived experiences into account and also allows us to extract generalizations and useful insights from a population in that sense. And so I'm actually, I guess I've been talking fast. I'm seeing I've actually been going through this a lot faster than I intended, which is fine, more time for discussion. I want to talk briefly about some work that is underway. Colleagues and I took advantage of a kind of natural experiment that took place. Back in September 2020, a person on the Ask Me Anything forum on Reddit asked formerly suicidal Redditors what's something that kept you alive a little while longer and helped you get through the dark times in your lives. This received between 16 and 17,000 responses within basically the next 24 hours. And it's important as a source of evidence for a whole variety of reasons, not least of which is the fact that so much of what we do in looking at suicide prevention is about assessing risks, reasons people die. But there is also a very, very important and perhaps less well-studied thread, Marshall Linehan and others, on reasons to live. What can we discover from a data set of people's lived experiences about what actually kept them from dying, and how can we use the insights from that in order to potentially affect interventions? So I just want to give you a little bit of a teaser here about the kinds of results that we've been seeing. And this is a collaboration where we're going to be presenting specifically on this at the Suicide Research Symposium, which is in a couple of weeks. One of the things, so these word clouds are not really word clouds. One might call them topic clouds because each one pertains to one of those discovered things, like you saw the line of words related to sports or the line of words that was related to anxiety or whatever. So each of these is one of those lines of words. But the size is sort of the importance or connection or relevance in making this topic what it is. And we've come up with a protocol that involves domain or subject matter experts looking at these things and then assigning labels. It's a form of computer-assisted content analysis, if you're familiar with content analysis in the social sciences. Some of this is confirmation of things we already knew and seeing how it was expressed in this particular collection with its particular demographics and population. So, for example, social connection is something that is clearly emerging as something connected with people not dying by suicide. Treatment, obviously, in the middle here. Religion, again, something that people have studied and know about here. What's most interesting, I think, are the things that emerge that, at least for the folks that I'm working with, would not have come to mind. Maybe the first one here on the left, pets, right? People are concerned about who's going to take care of their pets, or they joke about their cat eating their face off. A pet is something that's getting them through the dark times. In the middle and to the right here, one of the things that actually emerged was people talked about their video games. People talked about not just playing video games, but here and there, they talked about wanting to wait and see what the next release of the video game was like. Or, how is Game of Thrones going to turn out? Or any other kind of sort of new media stuff, their favorite YouTuber and what that's going to come out. Now, if you talk with a clinician about this, right, they might tell you that if they were actually in a session with somebody who was talking about this, this could derail the conversation, right? I mean, you could have a therapeutic rupture. What's going on here? We're talking about life and death, and you're talking about what the next episode of Game of Thrones is going to be. And yet, there's real insight to be gained here, right? One can't dismiss these things. The thing to do is say, if these things are emerging in a population of people talking about this, how do you use that in order to help them? Are there soft interventions that one can do that take advantage of knowing these aspects if the stuff that they're writing about is indicating, for example, that they fall in this category? Or maybe these things simply inform the therapeutic process and to ask about it because it is, in fact, something that might help, right? So this bottom-up approach gives us a bunch of stuff to learn that's different from just machine learning and labeling or the top-down approach of trying to identify things you know about. So the takeaways that I want to leave you with. One, automated labeling or classification is not enough in a resource-limited world. A lot of this is echoing things that people have been saying in this overall discussion. So we need more than just machine learning of predictive classifier models, period, in the standard ways, right? Population-level data, as I've just been talking about, holds bottom-up insights. I've also emphasized this dynamic of the experts helping the technologists understand what's possible and the converse of what's needed, and the technologists helping the expert community understand what's possible. Right? The famous line, which may be apocryphal, of Henry Ford saying, if they'd asked me, if I'd asked them what they wanted, they would have said faster horses. Right? So knowing what's possible helps inform the other side of the discussion. And finally, although I haven't spoken about it in detail, it permeates everything we're talking about today, last time, surely next time, and that has to do with access to relevant data. And I could give an hour-long talk about just this. My wife Rebecca calls this, my data rant. The very short version of this is that these kinds of technologies are years behind the stuff that is filtering your email spam or doing analysis of legal documents or doing type ahead on your phone or lots of other things involving language. A decade behind, say, right? Because we do not have communities with shared access to relevant data. Somebody has this data set, somebody has that data set. Working together on these shared data sets and shared problems is how communities make progress. The deep learning revolution that started taking place 2013, 2014, 2015 was really taking place, largely accelerating because of big shared data sets and the ability to work on them. And there are ethical concerns about access to data, but we always need to remember that those ethical concerns need to be thought of as a balance. In the Suicide and Life-Threatening Behavior article on NLP and suicide prevention, co-authored with April Foreman and Michelle Kushuk and others, one of the things we pointed out is that the ethical things go both ways. If you're terrified of sharing data, if the community can't, and individuals are scared of sharing data, right? There's an ethical issue that goes the other way of there are people who need to be helped, right? And so we need to find the balance between the concerns about privacy and consent and ethical treatment of data, the balance between that and the important uses that can be made of the data in order to help people. So I'll stop there and acknowledge collaborators, funding. Thanks so much.